I'm talking today with Ziad Nehme, a paramedic and researcher with the Ambulance Service of Victoria, and Harry Patsamanis, who's the Manager of Clinical Care at the Heart Foundation Victoria. Guys, thanks very much for your time this morning.
Pleasure.
Tell us about some research that you guys have done for us. It's been published on the 16th of January about the Heart Foundation's...
The warning signs of heart.
Tell us, Harry, a bit about the campaign for a start.
So the campaign started in 2009, so we ran an initial pilot in Victoria. The aim of the campaign was to really address the concerns that we had around patient delay. So there was a lot of research to show that patients were delaying their response to the warning signs of heart attack. And also some research that showed that the number of people who were turning up to hospital without an ambulance when they were having a heart attack was also alarming. So it was around the 50% mark. So 50% of people were coming to hospital with having a heart attack who were not using an ambulance. Right. The Heart Foundation looked at this as an area that we could address and devote some resources to. So in 2009 we ran a pilot of a social marketing campaign that looked at trying to address this with the general public.
So why are people delaying?
There's actually a lot of reasons why people delay. But the ones that we looked to try and address within our campaign was really around the knowledge that people have about the warning signs of heart attack. We know that most people relate chest pain as a warning sign, but not the other associated warning signs as well, such as neck pain, arm pain, pain between your shoulder blades, and also the other symptoms around nausea, dizziness, shortness of breath. So our role was to really try and get the community to understand that chest pain being a very important symptom, but there are others that people needed to be aware of. And in addition to that, we then looked at making people understand, or getting people to understand, that those symptoms are actually related to a life-threatening emergency. So if you are getting pain down your arm into your jaw and you're starting to feel dizzy and feel like throwing up, that actually could be a heart attack, not indigestion or a muscle strain. So that was an important aspect of the campaign as well. Then we wanted to build people's confidence to be able to call 000 when they were experiencing these symptoms. Because we knew very clearly from the work that we had done previously, when we did some focus group testing, a lot of people said that they wouldn't call an ambulance because they felt that if it was a false alarm that they'd be really embarrassed getting an emergency service to respond to what turned out to be indigestion, for example. They also felt that there were other people who would need an ambulance more so than they would. There were also people who were worried about the cost associated with an ambulance. But there were a lot of people who were also in denial that what they're experiencing is something really significant, because no one wants to believe that they're having a heart attack and that their life is at risk. So the role of the bystander in all this has a really strong effect. So we know through some of the case studies and the stories that people have shared with us when this campaign was running, that it was often a bystander, a wife, a husband, a child, a partner, who would make the call to 000 as opposed to the person themselves. There was a 45-second ad, which we called actually our dead man ad. So it really pictured a man who you see him on the cath lab table, who has actually passed away but then comes to life and relives his heart attack, and essentially says he wishes he had have understood that this was a life-threatening emergency based on the symptoms that he was experiencing, and made the call sooner so that he would be alive and with his family now. And that was a really powerful ad, and the way that it was filmed had a real impact, because we wanted it to have an emotional impact, not just a health message impact. And then we had a 15-second ad, and they were designed at the beginning to be top and tail. So you got the initial impact of the person saying, I wish I could have my heart attack again, I would do things differently. And the call to action in that ad was to get people to go to our website and download an action plan so that people could be better prepared to understand what the symptoms are and know what to do in that emergency, which was stop what you're doing, rest, talk, tell someone about what's going on for you, so involve the bystander, and then make the call to 000. And then we had a 15-second ad, which is a cardiologist that works out at the Monash Medical Centre, Ian Meredith, who essentially is coming out of the cath lab, taking his gloves off, and essentially saying to people, look, it's okay to call. It's an emergency. That's what 000 is there for. And if it turns out to be a false alarm, then that's the best thing that can happen.
Z, as I said earlier, you're a working paramedic. What's been your experience of the way or when or how people call you to help them?
Yeah, look, it's really interesting, and I think if you ask many doctors, nurses and paramedics, they'll all tell you horror stories. Probably among the worst of the horror stories is the mother or father who's brought by their family member to the emergency department in the back of the car in cardiac arrest, so it's already too late for that person. So for years we've been trying to overcome many of those barriers, and I think one important point before we get on to the war story, certainly, one important point about this campaign is it's very, very different to previous campaigns in Australia. We've run for decades campaigning around heart attack for many, many, many years. Many of those campaigns, many of the previous campaigns before warning signs were largely factual. That is, that we said to people, if you had chest pain, if you've got arm pain, then call 000. If it lasts for 15 minutes or more, call 000. But this campaign was different, not only different in its intensity, but also different in the way it tried to overcome some of the psychological barriers. And this is really important because those psychological barriers are exactly the reasons why we hear so many people they delayed in calling 000 or they delayed in fronting up to the emergency department. They're things like, I didn't want to trouble you, or I was scared to call the ambos because they're far too busy. We hear on the media all the time that they've got too much work to do, that response times are bad, that we need to try and reduce the number of calls to 000. So it was important for us to be able to create a message that's important, that says to the people with chest pain, we consider this a medical emergency. This is really important that you're calling 000 for and not driving to see your GP, not putting mum or dad in the back of the car and driving to hospital. We want you to consider this a worthy symptom to be calling 000 and calling us quickly. And I think this campaign really helps in overcoming some of those psychological barriers, and particularly this sort of idea of an embarrassment of a false alarm, or perhaps this indigestion or a non-sinister cause. But we hear it all the time, and certainly paramedics hear it all the time. I think I would like to hear those stories and to not hear them, because if you're not hearing them, then of course they never call 000 to begin with, but we'd like to see people calling sooner.
Do you think the public understands that the treatment for their cardiac arrest can start the minute you turn up?
No, I think they didn't. And not only the public, but also clinicians, the medical fraternity, if you like. We didn't, for a very long time, really understand the role of ambulance in the early care of victims who are having a heart attack. And I think in the last decade, certainly in the last 5 years, we've been able to really establish the role of ambulance. And we now know that if you're having a heart attack and you go via ambulance to hospital, the chance that you'll receive what we call reperfusion therapy, or open the clotted coronary artery, the chances of you receiving that therapy increases. But more importantly, the chances of receiving that therapy within national and international optimal timelines, if you like, also improve dramatically as well. One other thing that we've known for a long time, but we haven't really quantified until very recently, is this idea of having a cardiac arrest. Perhaps the largest and most significant complication of heart attack is if your heart stops. And if your heart stops in the community, the chance that you'll survive that event is probably less than 10%. So this is a really big issue and a significant cause of early death for patients having heart attacks. We now know that if you have a heart attack in the presence of a paramedic, you're 3 times more likely to survive. And of course, if you defibrillate and perform CPR, immediately when that happens, those chances of survival absolutely skyrocket. So the idea of putting mum or dad in the back of the car and driving them to hospital is no longer something that we want to see. We think that if you call 000 as quickly as possible, you have the paramedics there. If you suffer a cardiac arrest, your chances of survival are highest, and if you don't, or if you do for that matter, your chances of receiving the right medical treatment earlier is also substantially increased. The 2 biggest challenges in this space is number one, to show that a public education campaign can improve not only the response time for patients experiencing these symptoms, but more importantly, seeking that appropriate care. Very recently, we published a piece of work that showed that the Warning Signs campaign was incredibly effective at preventing 1 in 6 deaths from cardiac arrest, and that's really the first piece of work in that particular area that's demonstrated at all any sort of significant change in the incidence of cardiac arrest, which is really important. But one of the questions that was raised from that piece of work is, can we show that the reduction in cardiac arrest is actually, or the reciprocal of that is actually patients seeking more appropriate care. And that's really the crux of what we set out to do with this piece of work in the Medical Journal of Australia. And we wanted to look at the effect of the Heart Foundation's Warning Signs campaign on ambulance use for non-traumatic episodes of chest pain. So people calling 000 for non-traumatic episodes of chest pain.
So it ran for 5 years. So our campaign ran from 2009 to 2013 here in Victoria, and that's the time frame that we looked at the intensity and the when the campaign was in market and out of market, and Ziad looked at the Ambulance Victoria data around calls and out-of-hospital cardiac arrest and a number of other parameters to look at what the association might have been.
And you had a lot of data, didn't you? I mean, it's a huge sample size, really.
Yeah, so between 2008 and 2013, we had 250,000 responses. So, we need to sort of put this into perspective. Chest pain is our leading cause of lights and sirens call-out. So if we're going lights and sirens, it's most likely that we're responding out to somebody with chest pain. We see about 50,000 calls every year for non-traumatic chest pain. So we're not talking about a problem that we rarely see. This is our sort of, if you like, our bread and butter work, the things that we do every single day. And some of the implications of our study are quite substantial. So when we talk about 10% or 20% increases in calls, we're talking about thousands, if not tens of thousands of calls every year that are increasing as a result of the campaign. So
tell us exactly what the results were in terms of what the increases were for what groups.
So we can break down the results, if you like, into two sections. The first set of results look at the effect of a month with campaign activity, and they compare that to months without campaign activity. And what we saw is that any campaign activity on any month, we saw about an 11% increase in calls to ambulance for non-traumatic chest pain in comparison to months without campaign activity. Often when we see or we're exposed to an educational message on the media, the effects of that message trickle into the months after we're exposed to that campaign. And so we saw some residual effects, positive effects, if you like, in the months after, in the 2 months after the campaign was shown. And if you like, altogether, or the cumulative effect of the campaign was about 15% over a 3-month period from when the campaign started. So we're talking about probably about 400 to 500 additional calls every month for chest pain just as a result of the campaign.
Was there also an increase in false positives, if you like?
That's a really interesting area, because we often thought when we were running this campaign, who are the right people to make the call? And because our messaging was very strong to say to somebody, you need to recognise the symptoms, and if you have these symptoms and they last for 10 minutes or they're getting worse, then you need to make the call to 000. And we have absolute faith in the 000 system as an emergency triage, that they will determine whether this person has the kind of symptomology that is related to a cardiac condition that requires a lights and sirens ambulance to be sent to their home to assess them further. Because we know that if we made the message too complex, i.e., you have to have these symptoms, that it has to look like this, and you've got to exclude these things before you make the call, that's not the message we wanted in the community. So we always said to the community, it's not your job to diagnose your heart attack. Your job is to understand what the symptoms are and make the call to 000 and enter the emergency system, who will look after you and support you to go through the system. So we have had that debate around who is the right person to call, and when you look at the guidelines always say that kind of chest pain or that kind of symptomology needs to be assessed in an emergency setting, starting off with 000, paramedic, hospital, cath lab, whatever that might be, that sequence might be. And the one thing that we didn't want to do was make people have more doubt about when it's appropriate to call, and have the same kind of problem or a bigger problem where people are waiting to go and see their GP to have the symptoms assessed. So I think that who's the right person to call is a really interesting area, and we certainly thought about that at the front end. We were designing the campaign.
Certainly we saw increases in calls for ambulance for chest pain within subgroups of patients with acute coronary syndromes or suspected heart attacks or diagnosed by paramedics in the first instance.
Yeah.
But we also saw increases in ambulance use in populations that we thought were really hard to influence. You know, patients with a history of diabetes, for instance, are particularly difficult to influence, and those with a previous history of heart attacks or ischemic heart disease. I mean, who thought that people who had already experienced a heart attack would be difficult to try and influence for their subsequent heart attacks? But we actually showed that we're actually able to influence behaviour within those subgroups of patients as well. The really important subgroup, the ST elevation myocardial infarction, or the STEMI patients, the ones that are really time sensitive, we didn't see an overall improvement in their ambulance use for chest pain in that group. But what we did see was in the first year that campaign was run, we saw a 37% increase in ambulance use for STEMI patients. And in 2011, we also saw a subsequent increase. So what we're starting to learn is what pattern of media messaging is optimal to try and influence changes in behaviour for certain subgroups of patients. And as Harry said, we didn't set out to, the Heart Foundation didn't set out to deliver a message that was specific enough to target only heart attack populations. In fact, I think that is impossible. Unlike stroke has very specific symptoms, generally speaking. Heart attack is a lot more difficult, and the fact that you have chest pain or arm pain doesn't necessarily mean that you're having a heart attack. But what we're saying is that if you have chest pain or arm pain, then we classify that as a medical emergency, and you should be treated by a health professional as soon as possible. And I think what we've seen from that messaging is that we're actually improving ambulance use across the board, and we're now using some of those preliminary findings perhaps into the future to talk about how we might alter that message to try and improve the specificness, if you like, of the populations that we're attracting.
That was my next question, Harry. How does this research shape the Heart Foundation's next campaign?
So what we've learnt from this research and the evaluation that we did for our campaign was that people who had been exposed to this messaging were statistically more likely to actually have a broader understanding of what the warning signs are, be aware that they relate to a life-threatening emergency, intend to call 000 if it was happening to them, and be more confident to make the call. So we know that the messaging that we had out there originally, which as we said sort of was developed in 2008, started 2009, resonated really well. And the lifespan of that messaging was also really relevant. So we looked at awareness of the campaign throughout the whole time period that we were running it, and people's engagement with it. And those same ads had a lifespan of the 5 years that we ran the campaign, which was absolutely fantastic for us. Where we find now the gaps are is still in that question about trying to get more people into an ambulance when they're experiencing these symptoms. We haven't been able to affect that in a really big way from what we can tell. And also that issue around patient delay is one that we want to keep closing the gap for. Although we've seen a slow closing of that gap around how long the patient delays to activate the system, there's still room for improvement. So our next line of messaging that we're thinking, and calling it the next generation of warning signs messaging, is really about why does time equal muscle, or why is time so important for you when you're experiencing these symptoms, and getting people to understand that the clock starts ticking from the time that these symptoms are happening to you. And the other thing about ambulance and the importance of ambulance, and it's more than just a transport to hospital. We know that in country Victoria, people are missing out on pre-hospital thrombolysis because they're not actually activating 000 and going to the hospital. So adding another element of delay and confusion and triage and a whole range of other things that happen when you're not in that system. So we've done a lot of work in Victoria and across Australia in really tightening what we call the door to balloon times. And some of the advances in ambulance have been absolutely fantastic.
So we're evolving quicker than ever before, and we're understanding, particularly around stroke, myocardial infarction, and also cardiac arrest, how important the first few minutes are. And that's what will really change in this space, I think, in the future of medicine. We'll start to shift those therapies that were considered early hospital are now becoming very early pre-hospital. Just trying to bring it closer and closer to the patient.
We spend a lot of time and energy developing guidelines that interpret evidence and try and put that evidence into practice. So it actually talks about what does best care look like. And we, the Heart Foundation, in conjunction with the Cardiac Society of Australia and New Zealand, often update these guidelines, the acute coronary syndrome guidelines. And what we often see, or what we'd like to see, is the system responding to those. So how do our medical services improve? How does ambulance improve? How do we start to reach those benchmarks that we set ourselves?
Yeah.
What the Heart Foundation has done with the campaign is actually looked at that from the community perspective. So you could get a system to work really well, but if the community is not engaging with the system, then you're missing a significant portion of that. And that's why we made that decision back in 2008 to actually invest in that community side of the guideline or the system. And we want more people to engage in that particular way. And it's an incredibly difficult area to work in, and also quite an expensive area to work in. But what we've learnt over that time period is that it is possible, and the evaluation and the study that we've shown, that Ziad's put together, really shows that there is a real ability to affect this kind of change. But what we've also learnt is that it needs to be sustained, and it needs to evolve over time. And that's the challenge for us moving into the future, is how do we sustain this, and how do we evolve it to take the community on this journey with us. So starting from the perspective of people thinking, oh, this isn't really important, surely I'd know if I was having a heart attack. It's relevant for somebody, but not for me, because I'm generally young, I'm healthy, it's not on my radar. To a message that basically says, this is important for everybody, for yourself or for your loved one, because you might find yourself as a bystander in these circumstances. And we feel that we have brought the community on that journey with us to the point now where we can get a little bit more complex with our messaging around the idea of why does time become such a critical issue? What is the role of ambulance in improving your outcomes, your life expectancy, all those sorts of things when it comes to cardiac arrest and heart attack. So we're really excited about those sort of opportunities moving forward.
The only thing to add is that time is ticking. The campaign finished midway through 2013. That was a little while ago now. I think what we learned from the piece of work that we did in the out-of-hospital cardiac arrest setting is that when the campaign's finished, we saw a 7% increase in cardiac arrest incidents after the end of the campaign. So what we don't know is what's happening now, and what's going to happen in the next few years, and how long do we need to sustain mass media messaging or a form of educational message to the public in order for the message to get through and stay forever? Is that even possible? I'm not sure, but certainly time is ticking when we need to understand what the phase 2, if you like, of the sort of mass media messaging looks like, and what form they'll come in. I think that's really important.
Thanks for your time, fellas.
Thank you.